83-year-old female, 54 kilos, non-frail, independent, who presented to our hospital with spinea, class 3. She has no relevant comorbidities, only hypertension. And the surgical risk scores, as you can see, the score 2 is 2.1, and the STS score is 2.3. So this is low-risk patient for surgery. These are the lab tests and chest X-ray, unremarkable findings. Renal function is normal. On EKG, you can see sinus rhythm, no conduction disturbance. And on echo, the LV function is well preserved. 64 is the ejection fraction. The valve, the aortic valve is severely calcified. The mean gradient is 52 millimeters per mercury, and the aortic valve area was estimated as 0.6 square centimeters. She has also a mild mitral regurgitation.
In the CT find, we have an annulus diameter from 20 and 26, an annular area of 402, an annular perimeter of 72. The Valsalva diameters are bigger than 28, so it's okay. Next slide, please. So the LVOT is 19.5 and 26.2. The sinotubular junction is 28 per 32. And the extending aorta is 39 for 41.
So there is a dilation of the ascending aorta because she's a small lady.
She's a small lady with 41 of extending aorta. Yeah. So we interrogate a bicuspid valve. It has a calcified, no coronary cuspid, and a calcium score of 180/58. So when we are leading with a bicuspid valve or interrogating it, we should interrogate the valve at 4 millimeters from the annulus, the intercommissural distance. So it is 27.5. It's bigger than the annulus.
Yeah, it's difficult to say if there is a bicuspid or tricuspid on this case, right?
It's a fusion of the.
Yeah, it seems that she has a fibrotography.
When we are thinking about the bicuspid valve, we have a difficult to choose the valve size. So we simulated different THVs in different places from the aortic root, and to choose the best valve to deploy.
Before going that, is there any evidence, strong evidence to treat bicuspid valve with TAVR? Can you answer this, Dimitri?
Yeah. That's a very important question. I mean, there is no randomized data yet comparing the clinical results between tricuspid and bicuspid, but we have large registry, large observational studies that shown that the clinical results in bicuspid are very good, very encouraging, with low mortality, and low PVL with the newer generation transcatheter heart valves. If this is a really bicuspid type 1, type 0, to look for the amount of calcification and the distribution of calcification, if the raphe is calcified or not, just to decide between TAVR and surgery.
Okay,
so
great.
We are going to perform this procedure under conscious sedation using a minimalist approach. So we have puncture ulnar artery just for hemodynamics and for pigtail.
Why did you choose ulnar artery?
She has a very small radial artery. We saw this on the ultrasound, and we decided for the ulnar puncture. We did ultrasound guided puncture of the femoral artery, and we already placed a perclose. We are using just one perclose for TAVI cases.
Great.
And that's our practice.
That's great technique. So what you did more? So the pacemaker, you did a
pacemaker. This is a bicuspid, probably a bicuspid aortic valve. We're gonna predilate. It's our routine here to predilate.
In bicuspid, do you always predilate?
Yes. We tend to predilate all cases of bicuspid valves. This particular case, we are in doubt about sizing. And we're gonna do a predilation and we're gonna inject some contrast during full balloon inflation just to size the valve that we're gonna implant. And I think this is an important maneuver when you are in doubt about sizing.
That's the previous echo. Here we can see the parasternal long
Can you
axis
hear
drill.
Tito?
Yes, we do.
Are you hearing?
Hear him and see
Okay, good. Go ahead, please.
Okay, parasternal long axis here. We see both ventricles, the aortic valve, mitral valve. We see the increase in myocardial thickness here, a small LV, as they said before, thickening of the whole aortic valve with just a reduction of the mobility here. Just using the Doppler imaging, we have a mild regurg in the aortic side, a trace in mitral side, nothing significant. Apparently, the systolic function is preserved in both ventricles too. Just analyzing the short axis in the aortic valve, as the CCTA showed, we have the fusion of the right and left coronary sinus here, coronary leaflets, with a lot of calcifications and thickness. Max gradient just estimated in 84, mean gradient in 53. The area estimated in 0.6 centimeter square. Indexing for the burst surface area, we found a 0.4 centimeter square meter square. And about the function of the right and left ventricle, we cannot see any alteration of the contraction here, even in the 3, 2, or 4 chamber. Left ventricle ejection fraction is 64%. And systolic function of the right ventricle, just normal here, nothing than that.
So I'll present the THV characteristics, the MyVal. It is a balloon expandable valve that has intermediate size as the 21.5, 24.5, and 27.5, and extra large size as 30.5 and 32, in addition of the traditional sizes of 20, 23, 26, and 29. So the fact that we have the intermediate size and the extra large size is a factor that have to be highlighted. The another feature we have to highlight is that's the valve is crimped directly in the balloon.
Okay.
And it brings the possibility to retrieval the valve in case of inability to cross the annulus. It has a nickel cobalt alloy frame that gives a great head opacity and a radial straight. Okay, we have a PET puffing external to minimize the instance of PVL, and we have 50% of the valve is open cells. So it's good to coronary access, and as well we have a bovine pericardium leaflets that has an end calcification treatment. So as you can see, the valve has a pattern that you can see in the screen. So we have a positioning, to position is easier. So we used to position in the second dense band. So in the base of the pigtail catheter, if you can go on. So the valve, when deployed in this position, leads to 30 to 25% in the ventricular side. The navigator, we have a high flexion system and a great flexibility. Can you go? Move on. And the Python one is a 14 French expandable sheath. It is compatible with all the valves from 20 to 32, but from the 27.5, we have to predilate with 18 French. So our experience here, we have more than 150 cases since December from 2020.
Actually, was the first case in Brazil we did together here. Huh?
Yeah, we did the first case in Brazil. We have a good clinical results, low pacemaker rates, less than 1 digit, low PVL, and good hemodynamics.
How was the insection? So easy?
Yes. You are using a stiff wire.
Using a stiff wire?
Remove the dilator. Yeah, this is the angel that we already did.
Okay.
Also. And as you can see, it looks like a bicuspid on the floor, right?
Yes.
And the ascending aorta is also dilated.
Now
So
you're bringing the
wire,
Implantation catheter just to you have the wire direct to the valve, bringing back the stiff wire that you had, and now we have a straight wire to across the valve.
At this point,
now you're there.
echo doesn't help.
So the blood pressure looks okay. So 136, 140. Now trying to have the direction exactly in the mid portion of the valve. We got across the valve now with the stiff wire. We need to be very careful with this unplatted guide wire, unplatted catheter inside of the ventricle now. Now I have the wire inside of the ventricle.
Okay.
So careful and so gentle. Okay. Go ahead with the wire. You left the wire in the apex. The right position is the apex. Is correct, Dimitri?
Yes, we're gonna exchange the catheter for a pigtail.
Okay.
So it's not so easy to cross with the pigtail, right?
With the pigtail, that's what was mentioned. It's difficult sometimes. Now we got a better position. Go ahead, please, and go to the great position.
So let's measure.
So the procedure starts in any details. We need to be very careful.
So now we're gonna insert a stiffer wire, pre-shaped confida. And then we're gonna check on echo just to see the orientation of the wire. It's in the apex because it seems that the pigtail is in the lateral wall. It's not in the apex, right?
No, not on the apex.
So we're gonna try to reposition.
With the pigtail?
Yeah.
We're going to change for a soft one to get a better position. So
it's here.
Okay. Here. So now we are trying to position the guide wire in the apex of the left ventricle. Not recross again. Okay. Now is in the apex now?
Better now.
Let me see that.
It's in the apex, Tito?
Yes. Now it's almost there.
Sounds good.
Oh, it moved. No.
No?
Move it to the base now.
Lateral?
Lateral wall, still in lateral wall.
So we are going to change again. This is a hard part of the procedure, as Dimitri said. And because of the eccentricity of the valve, we could not drive the guide wire to the place where you want. Now we are bringing back the soft wire again. And try to place in the apex, as you can see here. We are going to recross with the implants. Do you understand what I mean? Bring the above of the camera, the above camera. Now it's we got there. Now we are going to jump one step. Instead of a soft wire and go with the pigtail, we are going to do the exchange with the competent wire. Being so careful, as we mentioned before, because of the small cavity of this left ventricle and also hypertrophy.
Looks better, huh?
Much better.
Yeah, that's okay.
Great.
Now that's on place.
Good. Much better.
So now we're gonna predilate.
Okay.
We're gonna use a
balloon.
A 20 balloon.
Okay.
We are a little bit undersized. Because the minimum diameter is 20, right?
Almost 20. And we can check the behavior and the position of the balloon and the THV.
Okay. Now you have the balloon exactly in the place. Now we need to check the pace. 120, 100?
180, 180.
180.
Okay, go ahead. So balloon up.
So the balloon inflation, inject. Okay.
And balloon down. Pacemaker off.
Facing.
Okay. Doing a predilation.
I think that we got a good ceiling with a 20 balloon. So we're gonna use a 21.5. 21,5, por favor.
So now we are taking the balloon out.
And we're gonna prepare the 21.5 valve.
We see a drop in the gradients, something around max gradient around 32 and mean gradient about 19.
Okay.
So could you repeat the mean gradient? How was?
19.
19.
19.
And how it was?
No, now it was 19. The
19.
mean
How was before?
grade. 54.
54.
54. Yeah.
So with this, just predilation, we went down from 54 to 19. So this is Corina
Yes,
crimping.
because we got a good ceiling with the
Okay.
20 balloon, right?
Okay. How long you're doing this? Por quanto tempo? 15 seconds, crimp the valve.
So valve is ready.
Yes, the valve is red now. Then Corina is bringing. Yes.
Also, it's really important to see the valve orientation. So it's really important to see the valve orientation. Here we have the skirt distal in the navigator. So the position is aortic position. We can move ahead, and the volume in the balloon is also important to share.
Okay. What is the volume in the balloon? 15 cc. Now it's showing so easily,
Yeah.
no
Yeah,
difficulty.
Was easy.
We already did the deflection here.
We are going to
So
cross
we're
the
going to
arch,
cross
okay?
the aortic arch.
Can I?
Yeah, go ahead.
Okay, let's move to the work position.
Yeah.
Good.
That's it.
A little bit
Next.
proximal. Okay. Now the valve, I think it's in a good
LAO4.
position. Okay.
So as you told me before, we can see the second dense band. Then we position this band in the base of the pigtail. Usually this position is okay for...
So in bicuspid and tricuspid is the same position, Dimitri?
We tend to implant the valve a little bit higher when you are treating bicuspid.
Jetta?
Yeah, I think it's a good position, right?
Okay,
A
yeah.
little bit down.
Yeah, it's okay.
Quem fica aqui?
Can I put the...
Okay.
Now we are 180. I think we are in a good position. Still the same position, Dimitri?
Yeah.
A minute, just seeing the...
180,
Okay.
vai, filma.
Now we are in
Injeta.
deploy the valve. Inject, please.
Injeta.
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 Tô indo aqui.
Injeta. Contraste.
Precisa não, precisa não.
Não, agora não.
Tem. Ok. 2,
Ok.
3, 4, 5.
So 1, 2,
Desliga
3,
o
4,
marca-passo.
5. Pacemaker
Pace
off. Okay, great. We pull back. The valve is in the place. Tito, now can you see the echo in the screen, please?
Yeah.
Echo in the screen. If you can have the echo in the large screen, maybe it's a little bit better, please. Echo in the large screen. Great, thank you.
Yeah.
Tito, the word is yours.
Yeah. First, we don't have pericardial effusion on our alteration of the segmental contraction. The valve seems to be in the good place. Let's see the gradients.
So no pericardial effusion, no aortic regurgitation. And now you are checking the gradient. Is that correct?
Yeah, exactly.
Okay.
The valve seems a little bit higher, but I think it's a good position for a bicuspid.
Okay. Now, what Dimitri is saying, it's the valve is a little bit higher, but I think it's a good position for a bicuspid.
Yeah,
We
our
have-
tendency now is to...
How about the gradient?
We have a max gradient about 6.6 and a mean gradient about 3.8.
Great.